Hi, my name is Dr. Terri Lewis, and I am a clinical educator with Southern Illinois University in Carbondale, Illinois. And I also work overseas with the Taiwan government as a rehabilitation clinical educator, helping the government to set up community-based clinical rehabilitation programs. I have a long history of interest in chronic pain and opioid tracking laws as it relates to the implementation of rehabilitation programs in the current environment. So this presentation is going to focus briefly on the emerging use of artificial intelligence as it impacts people who have multiple chronic illnesses and disabilities who are affected by artificial intelligence tracking. My interest in this comes from working with individuals who are receiving care in non-hospital settings. They are increasingly subjected to, they and their physicians are increasingly subjected to the use of AI tools to track prescriptions, to track personal behavior, to track factors that are associated with their movement in the community, all of which are assigned to risk scoring processes. And that has quite an effect on the access to healthcare for these individuals as it relates to public policy. So I would like to address briefly, to let you know what's coming, what my concerns are. Regarding data analytics and artificial intelligence, the data that comes into these systems is increasingly diverse. It comes from multiple system locations, and it's non-standardized. It reflects billing records, it reflects retrospective information, and it's increasingly used by government agencies to track fraud, waste, and abuse. That's an interesting concept when you're dealing with chronic care and community public health and personal health. The change of the opioid prescribing guidelines in 2016 led to the increased use of risk tracking tools and risk assessment. As I was working with this topic, I became very concerned about the use of opioid tracking tools and how they might function in terms of preventing or facilitating folks who are seeking care in the community. Of particular concern is the growth of the prescription drug monitoring databases that are now installed in all 50 states under funds generated by the Hal Rogers Act. It's important for us to understand that databases are not perfect instruments, and their use in policy design is theoretically to inform the implementation of and design of public policy. However, data construction is not transparent. And in an environment of procurement at the federal level, what we're seeing is federal contractors who come from private entities that are being tasked and awarded contracts to do what was previously the job of government. And that has real implications for the way in which we enter the healthcare stream and we facilitate healthcare across the system. So I conducted research. I've been doing it over the last 5 years, 6 years, since 2016 when the guidelines changed. I asked the question, what is the impact of these algorithms designed into interstate data sharing? And how do surveillance tools affect people with multiple chronic conditions who rely on controlled substances for long-term pain support in community locations? I used 3 methods here to begin to investigate this process. I started with a patient survey and used quantitative and qualitative analysis of both forced choice and open information fields. The second thing that I did was I explored and extracted patient outcome data reflected in these changes from 2016. And the third thing that I then did was I looked at the trends involved in data tracking and the use of how the PDMP might be affecting the results that I found in this investigation, and did a close examination of the design of the PDMP, what the expectations and assumptions are, and how it is affecting both patients and physicians. This survey received 4,635 completed surveys across 50 states. On average, the respondents were 70% female, and they were living in all 50 states of the Union. They had a history of comorbidities averaging on at least 7 multiple chronic conditions. I won't dwell on this because we'll discuss it at length later, but I did look at all of the drugs that were on the C2 list and asked the question how people were affected. Had their drug regimens changed? Did they have drug access? And was their access impaired or was it improved? And we'll be discussing some of that information. I also looked at how they accessed their physicians in the prescribing environment and whether they had lost physicians, whether they had been forced into specialized care, or what the status was of that. And we'll be talking about that at some length. And finally, based on the PDMP, I looked closely at what the Brandeis Tax Center offers us in terms of understandings about the use of this database technology and how a major contractor to this program, APRIS, has developed NARC's risk scoring systems based on the data that is available to them and shared both from the states and through the tax center. And what we found here is that the construction of the PDMP raises a lot of concerns about how data used in an artificial environment is designed, and whether or not the data has veracity, is reliable, and performs consistently to inform public policy is a really serious question based on the data that has been published by APRIS, which is the major developer of the NARC's risk score. We'll be talking about that. And I found that there were unintended consequences of the use of this system based on the way that this data is designed and our expectations for artificial intelligence. And there are at least 3 points to make here. congressional response to the illicit drug crisis has resulted in more than 500 separate public policy laws and regulations since the attention of the drug crisis came to our national consciousness. And sometimes these things work in conflict with each other. The algorithms that are designed to help us make some clarity out of the impact of these regulations have very real consequences to consumers who are disabled by chronic illness and rare diseases. And we'll be talking about why that occurs. Consequences include over-identification of disabled persons as potential abusers of controlled medications. Their care is disrupted, they are undertreated, the cost to the system is increased, patients are abandoned by physicians who are afraid of close scrutiny, and pharmacies have become increasingly reluctant to fill prescriptions. In some cases, the impact is great enough that we are seeing abandoned patients take their lives. So I am concentrating on 4 primary documents in my references, and I hope that you will join me for this discussion.